Thank you for staying with us. On this second half of One Slot, we'll be shifting our focus to cervical cancer. According to WHO, about 70,000 cervical cancer deaths could be averted annually in the African region if the efforts to end the disease by 2030 are urgently stepped up to ensure increased access to critical services for timely detection, care and prevention. Health leaders and donors meeting for the 73rd session of the WHO Regional Committee for Africa recently in Gaborone, Botswana, called on countries to act swiftly to bolster essential health services to adequately address cervical cancer in the region, which is home to 19 of the 20 countries globally with high burden of the disease. What actions must country take now to speed up a change in the narrative? To speak on this, I have an ART clinician, Ibadan Humanitarian of the Year and founder, Saving Women and Children Foundation, Dr. Dialins Noble. Thank you for giving us your time.
Thank you, Felicity. Good to be on the show.
The call, taking off the script of the WHO print, is countries are to act swiftly to bolster essential health services to adequately address this cancer. But before we amplify that call, I want you to give us a picture of what the situation is across Africa and specifically in Nigeria. What are they currently doing?
Before we dive into what is currently done, I would just like to give us an overview of what cervical cancer is all about, a brief anatomy, the physiology of the reproductive system, and how cervical cancer occurs. So cervical cancer is just a cancer of the cells in the cervix. That's basically what it is. But for us to understand cervical cancer, I will dig deep into the anatomy of the cervix. The cervix basically has some parts. I wouldn't dwell much on it, but I'll be focusing on the endocervix and the ectocervix. The endocervix is the part of the cervix that is connected to the uterus, which is also known as the womb, and the ectocervix is the part that is connected to the vagina. The endocervix is lined by a specialized type of cell called columnar epithelial cells, and the ectocervix is lined by some specialized kind of cells called the squamous epithelial cells. So there's a space between where these columnar cells and these squamous cells meet. That space is what we call the squamo-columnar junction. This part is very, very important for us to understand what goes on in the process of cervical cancer. So that squamo-columnar junction, as the reproductive system of the woman keeps advancing, and there's a surge in hormone, especially the estrogen. So what we see is that some parts of those columnar cells start eating or entering into the ectocervix. Yeah, so they start entering into the ectocervix, and after a period of time, that area that the columnar cells have eaten into the ectocervix forms a transformational zone. Okay. So that being said, for us to, for one to have cervical cancer, one has to be exposed to a sexually transmitted virus called the human papillomavirus. This human papillomavirus has a tropicity for affecting the transformational zone. It loves to affect the transformational zone. And this human papillomavirus has over 100 strains, but there are some which we have identified and classified as high-risk strains, and we also have those which are the low-risk strains. The low-risk strains are subtypes 6 and 11, and we have found out that they don't cause cervical cancer. Rather, they cause things we call condylomata. You hear things like warts, you hear things like lesion. Why
Doctor,
the high risk?
not to, I understood just a bit of what you were saying. Is there maybe a localized example that you can use to illustrate a little more what cervical cancer is? Maybe in a language that someone who is not familiar with the medical terms can easily connect to. I don't know. I know that's a bit hard, but see what you can do, please.
So for us to really understand cervical cancer, there has to be a risk of exposure to a virus called the human papillomavirus. Yeah. So this human papillomavirus goes into the body of the person and starts multiplying. This multiplication causes what we call precancerous cells. These precancerous cells, if nothing is done about it, it advances to become cancer. So there are risk factors for contracting the human papillomavirus. One of it is early coitus, which means when a woman starts having sex too early. Yeah. The second reason for this is multiple sexual partners, environmental factors like smoking. Smoking doesn't actually rest on just active smoking. Passive smoking is also as deadly as active smoking. We have issues around obesity because the challenge with obesity is that we, during our routine cervical screening, we can't really visualize the cervix. What this does is it causes delay in treatment and inability to even identify some of these precancerous cells. Human papillomavirus on its own is a self-limiting virus. It comes and it goes on its own without any medications. You really don't have to do anything. The body has its way of fighting this virus. However, if it stays for a protracted period of time, it can cause precancerous cells, and these precancerous cells can eventually lead to cancer. So that's basically what it is. So
Okay.
where we are now, Nigeria has collaborated with unilateral agencies like the WHO, the Clinton Initiative, some key stakeholders, and are supporting the country in the area of cervical screening and the process of implementing population. Can you hear me? Can you hear me?
Okay, I can hear you a little better. Your voice dimmed off a bit. Go ahead, sir.
All right. So I was saying that currently in Nigeria, cervical cancer ranks as the second most leading cause of deaths caused by cancer. The number one remains breast cancer. That tells you that it's a wake-up call for us. So currently, the country is liaising with unilateral agencies like the WHO, the Clinton Initiative, to try to increase testing services. So we are trying to implement a test and treat policy. However, some of these screening kits, they are not readily available, they are sparsely distributed, and the vaccine is ridiculously expensive.
So, I mean, thank you very much for starting off us on getting to know a little more about the cancer itself and how we can contract it. The focus really would be how we can deal with it, manage it, spread awareness. Due to low prioritization, experts are suggesting by governments, inadequate financial and human resources are allocated to the cancer control programs, cervical cancer specifically. How can we get governments to show more commitment beyond the rhetoric?
First of all, we have to define the problem statement. They have to understand the implications of cervical cancer. Then we have to also create an avenue where human papilloma vaccines are readily available. They are expensive. for a woman of reproductive age to be fully vaccinated, she may spend around 60 to 100,000 naira to be fully vaccinated. The government has to find a way to incorporate this into the national guideline for immunization so that these vaccines are gotten for free. We also have to, should I call it, meet or interact with their conscience in a way. Yeah, we have to empathize with these people and make them understand that if nothing is done in the aspect of testing, vaccine provision, even individuals who wish to have the vaccine is not readily available. There are a number of centers in the country that can beat their chest that they readily have the human papilloma vaccine. So the government has to also increase the health budget or cut down on some areas and see how we can make these vaccines readily available to women who actually meet the criteria.
There is another aspect to this conversation, and that's the limited capacity of health workers. There are comments that there is challenge to provide comprehensive prevention and control services, and then there is also low level of awareness and literacy about the disease. And then you've mentioned repeatedly the high cost of these supplies and vaccines. All of this hampering effective control. How have we been going about creating better awareness? Let's take one at a time. And in what ways can this be improved upon?
All right. First, we have to improve the health literacy of around cervical cancer, even around healthcare workers. If you're going to do a study, there are a lot of healthcare workers who have not assessed cervical screening. Cervical screening, we have different ones. We have the pap smear, we have the human papillomavirus DNA, but in middle and low income countries like Nigeria, we have found that a simple visual inspection under acetic acid can actually show us if there's a possibility of a precancerous cell. And the process takes just a minute. Acetic acid is readily available in various forms. We can even find it in things as simple as vinegar. So what we need to do is that we need to train more healthcare workers. We need to also liaise with community head, youth leaders, non-profit organizations who are centered around women and children. We have to liaise with them because we have to also go in to the grassroots. There has to be group calls, there has to be advocacy visits, there has to be meetings with key stakeholders in the aspect of increasing the awareness and explaining the implications of cervical cancer. So when we look at the doctor to patient ratio in Nigeria, it's the gap is so high. We are looking at a doctor to 100,000 persons. That person may not be able to cover. He may not be able to reach certain zones. We are talking about rural areas, hard to reach communities, people who don't even have access to the basic things of life. Because remember, we are yet to shut the gates around poverty, childhood marriage, female genital mutilation. So there are a whole lot of areas that indirectly can lead to or contribute or plays a role in cervical cancer. So we need to increase training. There has to be a learning, there has to be a relearning, and there also has to be an unlearning of what is already known and replaced with the right information. So by the time we increase our training of healthcare workers, we haven't including traditional birth attendants, because some of these people in the rural communities, they are the first contacts with some of these caregivers. So we
Doctor,
have
in
to
the interest of time, I want you to speak quickly as we wrap up. What kind of bold commitments and strategic investments do you envisage from government that will show clear intentions that is targeted towards, prevention, screening, not just screening, treatment and social support?
The first thing we have to do is incorporate it into our immunization schedule. That's the number one thing that needs to be done. There has to be adequate funding. If the money is not available, we can borrow to implement some of this. We can cut down on other areas. But the most important part, it remains prevention, because with cervical cancer, is a cancer currently that we can prevent and we can also treat. So why not just prevent it rather than treating it? So we have to include the human papilloma virus into the immunization scheme for all age groups, irrespective of gender, social status, religious beliefs, and individual status, basically. So we have to make them readily available. The government has to make that clear and bold step if we have to actually win the fight against cervical cancer.
Thank you very much, Dr. Noble, for speaking with us.
Thank you.
In closing, let me quote Dr. Matshidiso Moeti, WHO Regional Director for Africa, in saying that cancer illness is painfully devastating and affects families profoundly. But through early detection, care and prevention with vaccines, women and girls in Africa can be protected from cervical cancer. That's the end of the quote. All hands must be on deck. Thank you very much for watching. I'll see you another time. Bye for now.